Hello, I'm Myhra. I'm from Red Lake Nation, which those of you who are not familiar with that is in Minnesota and northern Minnesota. So I've been working as the behavioral health director at the Native American Community Clinic. Previously, I was I am a licensed marriage and family therapist, but I haven't been practicing for a few years. I've been focusing on administrative efforts, which I'll kind of outline here. This here. Okay, got it. So I feel like the problem has been outlined pretty well so far. I think the biggest thing I would talk about and highlight for Minnesota is that we really are seeing a lot of our deaths in the way of substance abuse or opiate overdoses. So the community that I'm working in is kind of ground zero for the opiate epidemic in Minnesota. We are starting to partner with some of our tribes around the area to address this issue. It's too big of an issue for any one agency or one government, whether it's the city or county, state, to address. So we're really working as an effort together to address this. I don't think there's much more to say about the intergenerational effects than what's been said, aside to say that one of the things that I've noticed from some of the research that I've done in intergenerational interviews with families is that historically there's been this protective factor around, grandmother or other family members really stepping up when a parent was struggling with alcohol use. What we're seeing now with the opiate epidemic is that families are using together, and what that's created is a challenge in trying to get the family in together to heal. So a lot of our interventions are really focused on the family. And then I would just add, as far as like the Native providers, one of our biggest efforts at NAC is really to work on workforce development. So making sure that we're identifying providers, Native providers, while they're in their training programs and training them and retaining them. Because after someone's already been trained somewhere, they're likely to stay there. So that's been one of our biggest areas of focus. So I'm going to kind of talk about the different levels of work that we're doing at the Native American Community Clinic. So a lot of this, I actually went out and toured South Central, and it was an amazing, beautiful center, and strive for that. So that was a number of years ago. And another story to tell later is I got chased by a moose and a baby in Anchorage, right in town. So the other thing that I would mention is our biggest effort is when somebody comes to the clinic, whether it's through our dental program, our medical program, or a behavioral health program, we screen for depression and suicidal ideation and anxiety and some other things. But essentially, what the next step with that is really getting them on a list to be tracked and monitored by our care coordinators. So we have care coordinators who are designated just to follow up on PHQ-9s and follow up with people who are coming out of hospitalization. The goal really is to get them while they're in the clinic. So a lot of times when we identify an elevated screening, we will have a behavioral health provider meet with them if they're willing, or if they're not willing, a spiritual care person. We have an elder and resident full-time who can provide that service, or a care coordinator. Our care coordinators are kind of really seen as a part of the community. They work with people's families for years and really have a really strong connection. So that's a real strength. We've talked a little bit about the shared records and the importance of that. That was a real controversial decision that we've gone back and forth, and it seems like over time we've continued to increase visibility between providers, and to the point now where we can see each other's full records now, and really see that that's very important in being able to share, I guess, work towards the same goals and see the care plans. And we do meet once a week to address some of this, but being able to see it on the spot while you're with the patient is really important, or before the visit. We have an outpatient behavioral health program as well, and that is really a training program where we bring in students and help to build their capacity. We also have a peer support recovery program that is embedded within this program, and we've sent them through the training, and they're not certified yet, although that is something that we're working to towards, and that a certification is required for billing, so that is something we're moving towards. But the peer recovery people are volunteers, so we've recruited them from the community and have trained them, and they commit some hours to that. We do hope to employ them. We've talked a lot about safety plans. I think the only thing I would add is that we really do think about that from the standpoint of thinking about opiate use as well. I think, as James mentioned, a lot of our communities, our Native communities, do have the substance abuse piece that is, I would say, kind of rooted in the same issues as far as kind of a sense of hopelessness around some of the historical trauma and things like that. So it's important, even if somebody's not identifying as having suicidal ideation, to recognize that their behaviors are that of, if they're having multiple overdoses and denying suicidal ideation, that's something that you really do want a safety plan around as well. Care planning, our care coordination. I think the important piece I would mention here that hasn't really been talked about is the importance of engaging the family in that support and care coordination and safety planning. So how we do that primarily is through having releases of information signed at the care coordination point with those people that they identify to be most supportive of them, and then kind of follow up with them if we do have someone we're concerned about and are not able to reach, and really getting that person engaged in the recovery. And then one of the really neat pieces that I appreciate about NAC and the work that we do is our community engagement. So the peer recovery program has really been very successful in kind of leading the way in this area, and our elder and resident. So what that looks like is if we have somebody who's wanting to get more connected with the community or wanting to do more around ceremonies, they can meet with our elder and resident or our peer recovery coach. They're available by phone, or they're available to take them to different events. That could be recovery focused or could be spiritual in nature, but we just find that that's been very successful. Another key piece would be our elder and resident has started an elder council that reviews our policies and procedures and kind of looks for ways to improve or where we might be getting stuck with getting people in and meeting their needs in the best way. So some of the tribal partnerships that we're working on and are in various stages of development. The one we've been working on the longest has been a MAP program. We have a prescriber in the clinic, and we have a lot of wraparound services that we provide in clinic. And then there's a dosing clinic that is in the same community that's through the White Earth tribe, which is another Ojibwe tribe in Minnesota. And I would point out that a lot of times that there can be a real negative connotation with MAT programs, and the thing that I find really interesting and exciting in the Native community is that it's really been kind of embraced as a recovery model, and that people, when they hear that their family members are getting involved in MAT, they get very excited about that and really want to be supportive. So I would say that that's something different that I've observed than other communities, and I've seen it be very successful as well. I kind of talked about the link between suicide and overdose. I'm trying to think of what else I was going to say about that. Maybe I'll come back to that. Intensive outpatient program. So we're opening, in partnership with the Red Lake Nation, we're opening an intensive outpatient program in Little Earth. So if you guys aren't familiar, Little Earth is a small housing project within Hennepin County, and Hennepin County is Minneapolis, and essentially that is kind of one of the centers of poverty in the area, so the most impoverished area. So essentially what we're doing is there are a handful of culturally specific programs for outpatient in the community, but we found that there's quite a few gaps, one of which is a harm reduction approach. So our plan is to kind of go into the housing project and have a program there where they'll have some expectations as far as how often they're attending groups and things, but really doing everything that we can to recognize that their family has been a real strength for them in their community and they don't want to leave their community. These are people who may have failed out of a number of different types of treatment programs. So we're really wanting to develop something for those who are kind of in the margins around what's going to be successful for them. Telehealth with Red Lake, I mean, we're talking with other tribes as well, but Red Lake is about 5 hours north of the metro and really has a difficult time with recruiting, as a lot of tribes do, providers. So we're in the process of setting up a telehealth program to provide diagnostic assessments to people in their shelter programs and their children's programs so that they can get services there. So this looks like an older version, but so one of the things that this partnership allows for is billing for services that are supportive, that may not be billable in other generally, so spiritual care, by providing some training through like UMI-CAD and things like that, we're able to bill for services that we may not otherwise be able to, and have a higher billing rate, and it has helped with sustainability. I'm not going to get too much into this for the sake of time, but the piece I would like to really highlight and how our intensive outpatient program is different is that we're really taking an intergenerational family approach. So having a family program that focuses on kind of some education and brings multiple generations of families together for a large group education, and then some breakout with individuals or smaller groups of individuals to talk about key themes that it came up and get more support in those areas. So achieving health equities. So of course, there's always the funding piece, that it's really hard to do all of this work when you're not able to get reimbursement for everything that you do. And for example, as a federally qualified healthcare center, we're not able to bill for services off-site. So if we go into the schools and want to do prevention work in some of the Native immersion schools, we're not able to bill for that. So I bring that up in that I see that that's going to be one of our core areas of work, yet it's probably our biggest barrier as far as our hardest group to reach right now with the way that our funding is set up. Workforce development, I kind of mentioned that. We just have a real shortage, and not only with behavioral health providers, but with Native American community health workers, peer support recovery people. So what we've identified is if we want these providers to be Native American and from the community, we're going to have to train them ourselves. So that's kind of the model and effort that we're moving towards. So funding, I would just mention that I know that there's a lot of funding that goes towards research, but I just challenge us to think about, what is the money reaching those who are most impacted, and are there other ways that we need to think about that, from whether that's services or where are the real gaps at. And I hope kind of talking about our program will provide some insights into what that might be. And I look forward to hearing you guys' questions.